So in our ADME study, the first topic of ours is absorption. We are studying absorption in this module. So let's say we took an oral drug. This oral drug goes from esophagus to our stomach. Now if this drug has to come in the circulation, it needs to cross this cell, and this cell has what? Lipid bilayer membrane. So if this drug is lipid soluble, then only it will be absorbed in the blood vessel, and this absorption is what we are going to study in this entire module. So the movement of drug from site of administration to the blood, this is absorption, and lipid solubility will be the most important factor. Why? Because the cell membrane is made up of lipid. Now the drug can be two type: acidic drug and basic drug. Now here we are learning some basics about the drugs. Let's say a drug is put in a water container. Drug, let's say HX, is put inside a container. Now it can either exist as HX in the water container, or it can be dissolved or dissociated into its ions H plus and H negative. So this form is the non-ionized form, while this is the ionized form. This is inside the water container. Now if the drug exists in this form, then these ions will combine with the ions of water, and the drug will be ionized or water soluble. Again, if the drug is put in water container and it dissociates in ions, it will combine with water ions to become water soluble. But if the drug does not dissociate, then it exists in what? Non-ionized form. So now it is water insoluble, or rather than we can say it is lipid soluble. If it's not water soluble, it is lipid soluble. So I know that if so from here we know that if we want to make a drug water soluble, we need that the drug should exist like this in the ions inside the water, right? So let's say what happens in our body. Let's say we took a drug orally, HX. If this drug is acidic drug, then inside the acidic environment of the stomach, it will exist as HX only. It will not be dissociated. So acidic drug will be non-ionized in acidic medium, while when this acidic drug goes in the intestine, the medium here is basic, so this acidic drug will be dissociated in ions, so it will exist in ionized form. So I can say that if the medium is different, means the medium of the drug is acidic and the surrounding is acidic. If the medium is same, then it exists in non-ionized form, and if the medium is different, let's say the outside medium is basic and the drug is acidic, so if difference is there, then it will exist in the ionized form. Same way a basic drug, when basic drug is put in acidic environment, it will be in ionized form, while in the basic drug is put in basic environment, it will be in non-ionized form. And now we all know that if it's ionized form, then it will not be able to cross this membrane. Why? Because only lipid soluble things can cross, not water soluble. So these ions will be dissolving with the water ions and excreted. So I know that, so from here we know that if I want to excrete this drug, then it should exist in what form? Ionic form. And here let's see, this is the lipid soluble form, so this will able to cross this membrane. So crosses the membrane when the drug exists as lipid soluble. So two most important things we know, that if the when the medium is same, then drug will cross. Means here let's see, basic drug, basic medium, drug crosses, and to excrete a drug it has to be what? Water soluble. Here it exists as ions which are soluble with the ions of water, so this will be excreted out. So water soluble drugs are excreted out. You know what our body does? Any drug, the body converts it into water soluble form so that it can be excreted out via urine, and it doesn't come inside the blood vessel or keep circulating in our body. So the most important thing to excrete a drug is to convert it in water soluble forms. We'll study it in upcoming schedule. So when the medium of the drug and the surrounding medium is same, then it is lipid soluble and crosses the membrane. When the medium is different, it is water soluble and do not cross the membrane. Done. So now let's say we took an acidic drug, aspirin. Nature is acidic and pKa is 6. What is pKa? pKa means that let's say there are 14 containers of pH 1, 2, 3 to 14. Now when I put this aspirin in this container which has pH of 6, it exists 50% as ionized and other 50% as non-ionized. So that pH 6 is the pK of aspirin. So here we can say that at pH 6 it is 50% lipid soluble or non-ionized and 50% water soluble or ionized. Done. So now I know that if I increase the pH, then this acidic drug aspirin will be more dissociated, right, more water soluble, and it will be excreted, rather than if I decrease the pH or make it more acidic, then it will be more lipid soluble or it won't get dissolved in its ions. So we have a formula, Henderson Hasselbalch equation, which if for any drug, let's say aspirin, we know the pH of the medium and the pK of the drug, then we can find out the ratio of H plus and Hx, means we can find out how much is lipid soluble or how much is water soluble or how much is dissociated or how much is non dissociated from. Done. So this was all mathematical calculations. Now we are seeing what actually happens in our body. Let's say the acidic drug aspirin is taken orally. Now this drug comes inside the stomach. So in the stomach it stays for 30 minutes, while in the intestine it stays for 3.5 hours. Now what does the logic say? If the drug is acidic, then it should be absorbed from where? From our previous studies, we know that if the acidic drug is there, let's say Hx is the acidic drug, then it exists as Hx here and H plus X negative here. So logically, it should be absorbed from the stomach more, and intestine it is less absorbed. But it doesn't happen like that, because inside the stomach the drug just stays for 30 minutes. In these 30 minutes we know that the acidic drug will be 99% lipid soluble and 1% water soluble over here. From this 99% which is lipid soluble, 20 molecules are absorbed in 30 minutes. But when this drug comes in the intestine, I know it is water soluble but 1% is lipid soluble, right? So in from that 1%, 100 molecules are absorbed because time is more. 3.5 hours the drug is sitting over here. So it can be absorbed more from here and less from here. Why? Because the time is more. Plus intestine has a larger surface area. So more absorption can be possible. So practically all drugs, even acidic drugs like aspirin, are absorbed more from intestine as compared to stomach, because pH is not the only factor. Acidic basic medium story okay, but important factor is time, surface area, many important factors are there. So intestine wins the race over here. Done. Okay, so now next topic is bioavailability. Let's say I took 200 molecules of drug orally. From this 200 molecule, 40 are excreted and only 160 can be absorbed in the blood. From this 160, 60 are degraded by liver and the 100 reaches the systemic circulation. So my input was 100 and I got my input was 200 and I got only 100 inside my blood. So bioavailability is how much blood is biologically available. Biologically available means whatever drug is inside this blood vessel will go to different cells, right, and the function will happen. So the amount of drug which reaches this systemic circulation is called bioavailability, and the ratio is taken from what? The input or an ingested drug we are taking. So what are the factors determining the bioavailability? For first is the excretion, right? Some of it is excreted and only some is absorbed. So one is absorption, second is first pass metabolism. If there is high first pass metabolism, and then the bioavailability will be low. Done. So it depends on two factors, just remember that: first pass metabolism and absorption. Now let's study deep about factors affecting bioavailability. First is absorption. As we know, if there is more absorption, then more drug is available biologically. Second is first pass metabolism. If liver is degrading more drug, then less drug is going to reach the circulation. Third is route. It depends on which route you are giving. If you are giving IV, then your bioavailability will be 100%. Rest oral will be minimum. How the most least one is oral. Why? Because hepatic first pass metabolism occurs in oral. In case of intramuscular and subcutaneous, it is somewhere between 75 to 100% done. But IV is completely 100% because you are putting the drug directly in the blood vessel, and that's what it is, the bioavailability, right? Done. So let's study some detail about sublingual route. See, if we take a drug orally, then it has to first get absorbed. Then the liver degrades some of it and then it reaches systemic circulation, right? In the IV route, we put a drug directly in systemic circulation, which is better, which is more biologically available. But in the sublingual route, we put the drug below our tongue. So from there it goes in these vessels and it is poured in the systemic circulation. So IV route and sublingual route are kind of same. They are putting the drug directly in systemic circulation. But what's the difference? See, both are fast acting, right? The difference is IV route and sublingual route is sublingual route I can put a tablet inside my mouth below my tongue all by myself. I don't have to go to a hospital or a specialized person. But in IV, in order to get the injection, I need to go to the hospital every day. So that's the disadvantage in IV rather than advantage in sublingual. Done. So let's say some patient have angina or chest pain. Now the drug of choice for this, or the drug which we have to take for this, is nitroglycerin, and it is taken by sublingual route. Why? Because it is emergency, so we have to take it in sublingually. Now I cannot make a IV drug for this disease angina. Why? Because the patient is going to get angina attack at his home, and it's emergency. He cannot go to the hospital to take an IV drug. So I need to make a sublingual drug for this condition, which is angina or chest pain. So the drug is nitroglycerin, and it had high first pass metabolism when taken orally. So we made it sublingual route. Sublingual route is preferred. Now what are the advantages of sublingual route? First, it is fast acting, so it can be used in emergencies. It has no hepatic first pass metabolism, and this is the most important. It is self administered, right? He can take the drug, he can place the drug below his tongue all by its own. And second is, see, after the desirable action is done, let's say he is having a chest pain right now. He took the drug, he took nitroglycerin, and after few minutes chest pain was over. He was not feeling any pain. So now what he can do is he can either ingest the drug or he can split the drug away. In that way the drug is not causing toxicity, right? The drug did its job. The chest pain was relieved. After that I don't want more drug to go in my circulation because the job is over, right? So I can directly spit it out of my mouth, or even if I ingest it, my liver is gonna break it down. So after desirable action is done, I can prevent the toxicity by myself also in the sublingual route. Done. So now, how do I calculate the bioavailability of a drug? Let's say a drug A is given 100 milligram IV. Now, what I need to do is I want to calculate the bioavailability of a drug by oral route. So first I will give that same drug by IV route, and then I will measure. First I gave it intravenously, and then I will measure the plasma concentration in the regular time interval. So initially, when the drug is given, it has high plasma concentration, right? When it is utilized, it slowly decreases. So drug decreases over time. So this is the IV graph. Now obviously, oral via oral route, the plasma concentration achieved will be less because liver is going to break down this drug. So this is the graph of IV, and this is the graph of oral for the same drug. Now I just have to divide area under curve of oral by IV, and I'll get the bioavailability desired for this drug. So bioavailability of drug A by oral route is the area of oral divided by IV. Done. Now, so here I can see that has more plasma concentration, so bioavailability of B is more than A. Done. Now, what is bioequivalence? Let's take an example. I have two brands of a same drug brand A and brand B. Now, what I did was I gave brand A 100 milligram oral and then I gave brand B 100 milligram oral. Now I calculated the plasma concentration. In brand A I got 50 milligram and brand B I got 40 milligram. So can I say that these are equal? Because from 100 I am getting 40, 50 inside the blood, and from this 100 I am getting 40, 50 and 40, so they're almost the same, right? But how much same is called bioequivalent? Let's say if this was 50 and this was 30, still I can call it bioequivalent or not? So for that we have, it should be 20%. So two brands of the same drug has almost similar bioavailability, not the same, similar, which is 20%, then they are biologically equivalent drug. So let's take another example. Here I gave two drugs 100 milligram same concentration, but from one I got 90 milligram plasma concentration, from the other I got 30. So these are not biological equivalent. Done. Now mostly all drugs that you get in market are bioequivalent, but some are not. For example, phenytoin. Now there is an interesting story. See, phenytoin is given for the treatment of seizures, and we have many brands of phenytoin. These are the two brands. You don't need to learn the name, just concentrate on the example. Let's say a brand A, the dose required for this brand to stop seizures is 300 milligram, and for this brand it is 500 milligram. So let's say there was a patient one which was taking this drug for the treatment of seizures. Now what happened was, the pharmaceutical company from where he was taking the drug got closed. So now he has to change the medical store, right? He was taking 300 milligram first. He changed to epitoin, but he did not change the dose. He did not took 500 milligram. He took 300 milligram epitoin only. Why? Because he was taking diltiazem 300 milligram. He changed the drug, but he did not change the dose. He didn't know that both the drug were not biologically the same. They were not biologically equivalent. So next day he got seizures. He went to the doctor and told that I took the drug 300 milligram as you suggested, but I got seizures. Why? Then the doctor said that the drug that you changed is not as efficient as this drug. The drug that you changed, Epitoin, you need to take 500 gram. It won't stop seizures in 300 milligram, right? So this was the example that gonna relate you to the concept of bioavailability. So the dose also has to be adjusted. Mostly drugs are bioequivalent, so you don't have to worry. Some drugs are not biologically equivalent. So now let's say I took aspirin 100 milligram. So the plasma concentration versus time curve shows this. So the initially plasma concentration increases up to the maximum value and then it decreases. So the time taken for the plasma concentration to reach its maximum value is Tmax, while the maximum concentration which it can reach is Cmax. So this was for 100 milligram aspirin. Now if I increase the dose, then I'll get a better or the more plasma concentration, right? If I see, it's simple. If I am giving you more drug, then obviously more drug will go into your blood, so your plasma concentration will be more. So more is the Cmax, so less is the Cmax here. Done. So Cmax, Tmax and area under the curve. See, area under the curve, this area, it represent what? It tells you the extent of absorption, and Tmax tell you how fast the absorption is or the rate of absorption, right? Now see, now I have to give a patient a drug, let's say aspirin. Now I have to decide the dose. So what dose I will decide? 100 milligram, 200 or 300 milligram. I need to decide from this dose that the plasma concentration should be below the maximum tolerable concentration and above the maximum effective concentration. So the maximum concentration of the drug which I am giving in plasma should be below this two line, right? So first I gave, let's say, 100 milligram of aspirin. So the curve came to be this, which was below the minimum effective concentration. This drug is not going to treat your patient. Then I increased my dose to 400 milligram. Now the graph came was this. So it is above the maximum tolerable concentration. The patient is not going to tolerate 500 milligram. So I'll have to give 300, which is in between this. The peak is here in 300 milligram, which is below this two. So maximum tolerable concentration and maximum minimum effective concentration. So that's all for today.